Yes, sir, you can start now.
Thank you. Thank you. Good evening, everyone. It's absolute pleasure to welcome you to all our respected experts, includes IVF doctors, gynecologists, and especially embryologist doctors who are the catalyst of this webinar. And few doctors from the different parts of the world. Welcome to you all. We truly delighted to have you with us for the UNS AHERA scientific webinar. Talking about the UNS, we believe every scientific discussion has the potential to transform patient care. And as one of the fastest growing nutraceutical company, our mission is to bring evidence-based innovations that help clinicians to achieve the better reproductive outcomes. In our infertility portfolio, which includes CoQ range, starting from CoQ 300, CoQ Forge. We have a male infertility focused product like CoQ LC. It's our advanced male infertility formulation, specifically designed for the patients who are having oat care. Oat. By combining the formulation is like L-carnitine, ubiquinol, astaxanthin, zinc, and selenium to improve the sperm quality and the function. The complementing the to this CoQMAN, we have this is a patented formulation which is developed to address male sexual health concerns and including erectile dysfunction as well as reduced libido. So today's webinar is another step to our journey of learning with the collaboration, scientific excellence, and we are confident that expert insight shares today whatever will provide the valuable clinical perspectives and that will be translated into everyday practice. With this, it's my privilege to invite our conveners, Mr. Siddharth and Ms. Priyal, to introduce our esteemed faculty and speaker and officially begin the exciting scientific session. Thank you, and I wish all wonderful learning experience. Go to Siddharth and Priyal.
So thank you, Nakul. My name is Jayesh, and I will take over the introduction part. So on behalf of IHERA, Andronet, and UNS, I extend a very warm welcome to all our distinguished speakers, moderators, panelists, and participants joining us from across the country and beyond. It is my privilege to welcome Dr. Ved Prakash sir, who is founder of IHERA, whose vision has been instrumental in advancing education and excellence in clinical embryology. Professor Sanjay Shukla, who is a co-founder, who is a passionate embryologist and mentor dedicated to strengthening reproductive medicine through knowledge sharing. And Dr. Charudat Joshi sir, again a co-founder whose continued commitment has helped build collaborative platforms for learning and professional development. I would also like to welcome our conveners, Dr. Hetal Shukla sir, Dr. Devan Patel sir, and Dr. Durai Palani sir, whose leadership has been central to organizing scientific programs like this on a regular basis. With this, I will request Ved sir to say a few words before I introduce you all to the program. Ved sir.
Thank you, Jayesh. As Nakul already said, and Jayesh also mentioned that we are doing this kind of program since so many years, and I think this one is our 7th year from IHERA, and Andronet we started recently last year, and successfully we are doing this kind of knowledge sharing program for all the people who want to learn and use this kind of information in their daily practice. So today, again, the very good theme we have selected, that the crisis of male infertility, is it real or not? So we have so many speakers from other stream also, psychosexual and sexual therapist also in this panel. And of course, Dr. Satish Dipankar is also here, who is going to speak very good that same topic on crisis of male infertility. So I think welcome you all. Thank you so much.
Thank you. So today's program, as Ved sir rightly said, is the silent crisis is male fertility declining. It will address an issue of ongoing, growing global concern. Male reproductive health is increasingly becoming a focus of both research and clinical practice, making discussions like today's even more relevant than ever. We are privileged to have an outstanding panel of experts who will share their perspectives on male fertility trends, fertility preservations, and the challenges which will help us in shaping the future of reproductive healthcare. So without any further delay, let us begin our today's scientific session. To begin with, I will like to introduce my co-coordinator, Mr. Siddharth. Mr. Siddharth Morvadia is a senior embryologist. He has a keen interest in research, keen interest in male infertility and automation in IVF. And he has been faculty for many national and international conferences and has presented on various platforms. Over to you, Siddharth.
Good evening, all. Am I audible?
Yes, you are audible.
Good evening, everyone. So today our first speaker will be Dr. Satish Dipankar sir. He has done his MBBS from Government College of Miraj, and he has a lot of experience in andrology, ample of years of experience in andrology. And as we know, today's talk, as this month is about andrology, so I couldn't find anyone better than him talking about the same topic. He has many research on his names on the andrology side and the COVID side also, and he has more than 35 research papers in national and international journals. We are grateful to have you, and we are looking forward to listen from you, sir. Over to you, sir.
So shall I start?
Yes, you
Yes,
can
sir.
proceed, sir.
Okay. I'll share my screen. Is my screen visible to all?
Yes, sir.
Yes, sir.
Yes, sir.
Sir, please make it presentation mode. Yeah, perfect.
Thank you. So today we are going to discuss this current crisis in is the male fertility declining. Thank you for the organizers. They have selected a very nice topic, as this June is the main health month, and we are going to discuss about the men's health. And let's start. In today's topic, we will discuss whether the male fertility is really declining and what the crisis is related to this today's topic, and what can be done, what the preventive measures can be done. Let's begin. So regarding today's topic, we will discuss the current evidences related to male fertility trends. We will discuss the causes of declining semen quality. We'll discuss the difference between semen quality and fertility. We'll discuss the common misconceptions or myths in the society related to the male infertility. Also, we'll discuss the importance of early evaluation of male infertility and some practices or some strategies, public health advisories we'll discuss to find out the solution on this male infertility. So, if we see from last decades, the quality of there is a increasing cement quality is decreasing in the last few decades. The worldwide publications and researchers, they have published the articles in which it has been proved that the main semen quality is going to be decreased in terms of semen, sperm count, sperm motility, morphology, etc. So all over the world, this male infertility issues are increasing. That is proven by these published research articles. So these delayed marriages and late marriages, adulthood, these are the contributing factors of this decreased male infertility. And lifestyle changes, obviously the lifestyle changes, environmental factors are contributing the male infertility issues. We'll discuss later on. So, are these, sorry, are men becoming less fertile, or are we measuring the fertility incorrectly? What does the evidence says? The recently published articles, also the article meta-analytic studies published all over the globe, they have proved that sperm count is declining, and it is continuously declining. The meta-analytic study conducted by this Levin et al. In 2022, they have shown that the sperm concentrations have declined from 101 to 49 millions per ml. So that is about nearly 50% decline in sperm concentration from 1970s. From year 2000, the data demonstrates that there is a increased in there is a decline in sperm quality, sperm count from 1% to 2.6% per year. Another study conducted by the Pepcon and other et al. They have discussed this geographic variation in the semen parameters. They have collected data from all over the world, and that is published along with the WHO, World Health Organization. And it has shown that there is a decline in semen quality in terms of this sperm count, sperm concentration, volume, motility. But this decline in semen quality is not all over the same all over the world. It varies geographically. There is a geographic variation in the decline in semen quality. If you see in this diagram, there is a more decline in semen quality in Africa, USA, and African countries. Also, if we see the comparative chart of this WHO manual for human semen analysis from 1982, current edition, that is sixth edition, released in 2021. If you see that, there is a decline in semen quality, the sperm count, and other things. So this is the major concern related to this men's health or male fertility potential. So also, if we get cases in our labs or our OPD, what we see that there is a male factor contributes nearly 50% among the infertile couples. The male factor is about 50%, which contributes the infertility among infertile couples. So this is the major factor of concern. The male factor should be paid attention among these infertile couples. What might decline the semen quality? There are so many factors which are contributing the decrease in semen quality. Today's change in lifestyle, intake of fast food, intake of bakery food, sedentary lifestyle causing rise in obesity. In India is now also in the race of the increasing obesity, the advanced paternal age or delayed marriages, infections, sexually transmitted diseases, poor sleep, exposure to the blue screen, exposure to the mobile computer screens for whole day, that is also causing a decline in semen quality. Stress, physical stress, mental stress, both are contributing the decline in semen quality. Exposure, maybe due to the professional exposure or handling the computers, laptops for long time. The keeping the laptops on the close to the body will release the heat, and that will decrease the semen quality. Apart from that, there are environmental factors which are playing a great role in declining semen quality or decreasing the fertility potential. After World War II, the air pollution has been increased tremendously. Smoking, alcoholism has been increased. Um, Use of plastics also increased after this World War II. Use of plastic in daily life, use of plastic bottles, the keeping of this plastic containers in the fridge store, that is storage containers in the fridge, that also causing the plastic poison. And there are also a lot of this microplastics are found in recent studies A lot of plastics are found in the human bodies that are causing the various health issues, including this male fertility or decrease in semen quality. Intake of heavy metals through exposure to the heavy metals, exposure to the or the intake of heavy metals through the poisoned fish or poisoned meat, uh, eating of these food, eating of these fruits which are exposed to the heavy pesticides, the sunflower and other things, the cabbage or other so many vegetables nowadays. They are full of pesticides and they are directly going into the human bodies. Endocrine disruptors, use of these perfumes use of perfumes. That's perfumes contains endocrine disruptors, and that they are causing the disruption in the or they are disturbing the hypothalamus pituitary gonadal axis that will ultimately affect the semen quality and fertility potential. So there is a huge, great potential negative impact on this sedentary lifestyle, exposure to this pesticides, heavy metals, use of plastics. All these are contributing the uh, decrease in semen quality, decline in semen quality, decline in sperm count, motility, morphology, sperm morphology, ultimately leading to the decrease in semen quality and male fertility potential. So already this studies has been published. So many studies are published. Oxidative stress. This is the many times the andrologist or the gynecologist we discussed this. Oxidative stress is a contributing a major factor which will cause the sperm DNA damage that will lead to the reduced fertility and miscarriages. That is the one of the cause of unexplained fertility, unexplained infertility and those things. So what we see today in media, today's media is showing the exaggerated things as humanity is running out of sperm. Men become infertile by 2020, 2045. Is it true? No. The average sperm concentration has declined in many populations, and there is a geographic variations, but this does not mean every man is infertile. So this semen analysis, this is the basic investigation that we carry out once the males are referred to the andrology lab. We carry out the basic test, that is semen analysis, a very good test in which we test the sperm count, we check the sperm volume, semen volume, we check the sperm motility, sperm morphology, etc. But this mere examination of semen, that is semen analysis, it will not clear the fertility potential. It will not help us what are the chances of or percentage of the pregnancy. It will not reveal the genetic competency, or it will not tell us about the quality of the embryo. So what is the difference between this semen quality and fertility? We have just now I have told semen quality. These words are repeating the semen quality and male fertility potential. So what is the difference between semen quality and fertility potential? Semen quality is just a specific measurable characteristics of a man's semen sample, just examination of the semen. It is a laboratory test, laboratory assessment, which will help in the detection of the semen quality in terms of sperm count, sperm motility, morphology. And what is meant by fertility? Fertility is a functional biological state. It is an actual biological ability of an individual or couple to conceive the child through sexual intercourse. Further differences between the semen quality and fertility. The semen quality just now discussed is just a lab test, semen analysis, and while the fertility potentially tracked by the couple's ability to conceive over a period of time, that is 12 months of unprotected sex. Independence, that is the semen quality, solo measurement of male partner's sample, while the fertility is the shared outcome depending upon the both partners' reproductive system. The predictive power of the semen quality, Just it cannot guarantee the pregnancy, while the fertility potential is the ultimate confirmation of the reproductive success. So the fertility is more than sperm count because it involves both the partners, while sperm count or semen quality involves only the male factors related to the sperm count, motility, sperm morphology, and sperm DNA integrity. While fertility is the measurement of the uh, both male and female partners in terms of their fertility potential. So fertility is a couple phenomena. If you compare with the semen quality, fertility is a couple phenomena that will help in the pregnancy. Interpreting the evidences, if we see the evidences or the publications published all over the world, though there is a geographic variation. The infertility issues or the semen quality is not equal all over the world. There is a geographic variation. In one part of the world, the infertility issues are more, while in other part of the world, comparatively, it is less. Also, there is a laboratory variations are there in case of this determination of the semen quality. Of course, selection bias, trained staff, what methodology we use, depending upon that, semen quality or the semen report may vary. Different abstinence period. Some labs, they will strictly follow the abstinence period of 2 to 5 days, while other labs, they will follow 2 to 7 days. That will also play a minor role in detection of this or determination of this semen quality. So evidences suggest a trend, but they are not a full proof that men infertility is equal all over the world, or though as the media's exaggeration is showing that there is a total infertility by 2045. That is not true. The semen quality is it gives more idea about the men's general health. The poor semen quality, if we see, when the patient are visiting the andrology lab, if we check the patients or if we take the history, the most of these oligospermic males or infertile males, they are suffering from other metabolic disorders, other diseases like diabetes, obesity, hypertension, cardiovascular diseases, like etc. So semen quality not only gives the information about uh, the fertility potential or just reproductive health. The semen quality reflects the overall health of the person. Just by examining the single drop of the semen, we can tell that the person is under stress. The semen may contain a lot of WBCs that will reflect some infection. Leukocytospermia will reflect the STDs or infection. The presence of a lot of agglutination, presence of semen hyperviscosity, all those things will reflect that male is under stress, and the person may be suffering from some other diseases. Uh, though we check that male fertility potential, or though we check the semen quality, but male may be suffering from so many other diseases. So just examination of single drop of semen, it will give a lot of information. We have published the one article, the comparison of this semen quality with the heart rate variability. That the heart rate, in oligospermic males, the heart rate variability has been found to be decreased. Can fertility be improved? Yes, fertility can be improved by changing lifestyle, by decreasing the weight in case of obese patients, by having a regular exercise, by having a balanced diet, adequate protein. The Indians have less amount of protein in our diet. Most of the Indians, we take a lot of carbs and lot of oily food, and proteins are deficient in our diet. So adequate amount of protein should be there. Cessation of alcohol and smoking, those are having habit of alcohol and smoking. Adequate sleep, minimum 8 hours of sleep is must. Stress reduction, is now everybody's suffering from stress, and in their day-to-day life, in this world of this competition, stress is there. Stress is, we can't avoid the stress, but still we can we can manage the stress. We can have the mindfulness practices through which we can reduce the stress. Apart from that, there should be a balanced food. Apart from the balanced food, there should be vitamin supplements, micronutrients should be given to the males to improve the health, not only to increase the semen quality, but to increase the men's health. So eggs or proteins, the dried fruits, vitamin C, CoQ enzymes should be included in the diet, or other health supplements should be included in the diet. Apart from that, to achieve the pregnancy, or to increase the fertility potential, the male can be evaluated, and uh, the required therapy can be given at the last. This is the last thing. In case of infertile males, the ART can be, optimum ART should be given to the infertile males. How to evaluate this male partner? There is a basic evaluation. It starts from the detailed history, physical examination, semen analysis, including sperm DNA fragmentation test. Mere semen analysis will not give information about the sperm health or male fertility potential. Although we can include hormonal profile whenever it is required, scrotal imaging in selected cases, the USG of scrotum, genetic testing in severe infertile males, public health implications. So uh, male fertility decline, it may give signals about the environmental health risk. The person may be exposed to the environmental pollutants or heavy metals. Sorry, the delayed family formation definitely challenges. It will decrease the fertility potential, and there's need for prevention of focused reproductive health policy. So some common myths are there in Indian society. So like that, normal sperm count means fertile. That is not true. It is false. In our lab, one bank manager visited, and we checked his semen, and there is a lot of semen hyperviscosity and agglutination was there. But he was telling that, doctor, my sperm count is normal, and why we are not having pregnancy? Why my wife is not getting pregnant? Uh, though he was having normal sperm count, but most of the sperms are agglutinated, and he was having the semen was having severe semen hyperviscosity. It was not getting liquefied after 60 minutes. And uh, such things people don't know. Just they know that if the sperm count is normal, they should achieve the pregnancy. Low sperm count means sterile. That is also false. One semen report defines fertility. That is also not false. There should be further minimum 2 semen analysis should be done. Male age doesn't matter. That is also false. Infertility is mainly related to the female partner only. That is also false. Why males are evaluated late? What some common reasons are there? There is a social stigma. Means they will avoid to get evaluated. First, they will try to evaluate their female partner, and considering that the female partner is responsible, or female partner may be infertile, and there's a lack of awareness in Indian population, delayed referral, some fear or anxiety. What may be the report? Report may contain low sperm count, or if what will happen if I get proved that I am important, and like that. Some myths are there in Indian society. So because of this, some factors, the males are evaluated late. So in such case, what can be done? What should be done? We should encourage early male fertility evaluation by simple methods. Whenever the patient visit to our lab, take the detailed history, have a detailed physical examination, including the examination of the testes, the detailed semen analysis, if possible, do the sperm DNA fragmentation test also, hormonal profile in case of prolonged infertility, ultrasonography of scrotum, truss, genetic evaluation can be done in severe infertile cases. And also uh, we should train our patients to have a self-testicular examination once in a month. Just like breast examination, we are promoting to the female patients, and like that, this testicular examination, self-testicular examination should be promoted to the male patients. And otherwise, they should get examined by their urologist or their doctor at least once in a month. So, improve the awareness that infertility is not related to single partner, it is a couple issue. Promote healthy lifestyle in both partners, boys, males, and both the partners. Reduce or avoid harmful environmental exposures and reproductive health literacy. That should be promoted by government as well as the ART clinics. Further, what can be done? The standardized semen surveillance and research, standardized ART laboratories with quality control. We should check or we should employ the trained staff in our ART labs, ART clinics. Avoid common mistakes. Ignore the under evaluation or ignoring the male partner. That should be avoided. Over interpretation should be also avoided. Treating every minor semen variation as a disease, and there should be a balanced approach. Balanced approach in terms of semen examination, balanced approach in terms of infertile couples. Both partners should be evaluated. The future directions, inclusion of this artificial intelligence, digital semen analysis. Sometimes the digital semen analysis also should be accompanied with the manual method. Biomarkers, presence of the biomarkers in the semen, proteomics, genomic study, epigenetic study, like that. And some personalized reproductive medicine should be included. What are the uh, further what we can achieve? There is a singles, we should avoid the single semen analysis. There should be repeat semen analysis, meaning after 3 months, minimum of 3 months. Treat reversible causes. Treat reversible causes. And ART treatments. Evaluate both the partners simultaneously. And the therapy should be couple centered. The infertility evaluation should be couple centered, as well as the further treatment counseling should be a couple centered. Couple centered evaluation history can be taken, and depending upon that, or if any partner is infertile, we can proceed. For example, if we conduct the couple centered evaluation or history, if we get male is infertile, then carry out the basic semen analysis, DNA fragmentation test, repeat semen analysis. If it is normal, then just treat it as an unexplained infertility, give the supplements, lifestyle modification, the fertility potential may improve. If repeat and semen is also abnormal, further we can proceed for the further treatment, hormonal profile, or further evaluation, we can proceed. What is the take-home message? The silent crisis. The real challenge is not just declining sperm parameters, but delay in assessing and addressing the male factor. Avoid under evaluation, avoid over interpretation, promote early evaluation of the male infertility, promote healthy lifestyle, promote couple-centered fertility care. Early evaluation of the male partner is more important than focusing on single semen parameter alone. So thank you for giving opportunity to talk on this topic.
Thank you. Thank you so much, sir. It was a great lecture. It was great to listen from you. We are open for questions.
I think Dr. Satish has done very good job actually. The last take-home message, it is that written over here. The real challenge is not just declining sperm parameter, but the delay in assessing and addressing male factor. This is really very good actually. We are not actually focusing on that main thing. We are assessing male. Basically, we are delaying the assessing part. We are not checking at the that early evaluation and healthy lifestyle. We are not more focusing on that now. Of course, people are focusing on healthy lifestyle also. So it is good that whenever patient is coming, you start the evaluation at starting point. Like patient first time he's coming with wife, then I think we should take at least one semen sample to check the patient male partner. I think it. Thank you so much, Dr. Satish. It was excellent lecture. And if we have some questions, we can take. Dr. Devan, do you have any
So
question?
just by examining semen analysis.
Yeah.
Yeah. Sir, I would like to ask the question that as you told that we should male should come forward for early semen analysis, but this message is not going to actually to the common people. I think what we should be really doing, like what kind of messages should we promote, and maybe some government agency should get involved, because now it is kind of indirectly it is a disease now.
We should promote, sir, this reproductive health
But still, sir,
policy
this
and
is very less. Yeah. So, like, see, we scientific community, we are discussing, but then
yes,
it
sir.
is not going to the common people. Like, okay, we, as you suggested, definitely we should ask all youngsters to go. But that message, what kind of platforms we should be using, that it should reach to real common people.
Yes, sir. Previously, it was not at all, but nowadays, this awareness related to male infertility is slowly increasing. Although this our country is having a huge population and country of diversity, but still, I have seen that from my journey from AIMS Patna to AIMS Mangalgiri, the this literacy related to this male infertility is slowly increasing. Earlier, the only female partner was only investigated, and female partner was only blamed related to the
Correct.
case of infertility of a couple. But nowadays, males are also visiting the urologist. They are visiting to our labs. They are directly contacting. I want to undergo my semen analysis. Even few patients we have see we have few males have visited before marriage also. They want to undergo their semen analysis. Though the rate is less, but slowly it is increasing.
I think it should come into teaching also. Maybe
Yes,
I don't know, not at least in 10th or 12th, but maybe somewhere people should get, youngsters should get educated that this is also very important.
yes, sir. Sexual education and everything should be included in the
Yeah,
from school time.
yes. So at least early semen emulation, I think, should be promoted.
Yes, sir.
So I think thank you so much, Dr. Satish. It was excellent lecture, and definitely we look forward for sometime later also this kind of lecture. Thank you so much.
Thank you, sir.
Siddharth, can we take second lecture now?
Yes, sir. Sure, sir.
So, good evening, everyone. I hope you all enjoyed our first scientific session and found it both informative and thought-provoking. So, it is now my privilege to introduce our next distinguished speaker. So, that can we have, please, introductory slide of her?
Just a second, Ash.
Dr. Bindu Chimote, who will be addressing us on the topic male fertility preservation in the era of delayed parenthood. Dr. Chimote is an accomplished IVF scientist and consultant clinician embryologist. She holds an MSc in biochemistry, an MPhil and PhD in reproductive biology, and MSc in clinical embryology from the Leeds, UK. She has presented 17 original research papers as first author and 43 as co-author at prestigious international scientific forums, including ESHRE and ASRM. She is the recipient of the ASRM in Travel Training Award in 2013 and the Best Poster Video Award at ASRM 2019. Dr. Chimote has published 14 research papers in international journals, contributed to 14 chapters, and into national and international books on infertility, including invited chapter in the prestigious Elsevier book series, Vitamins and Hormones. She also serves as a reviewer for the leading international journal in reproductive medicine. And her major area of research includes follicular fluid, metabolomics, endometrial receptivity, reproductive biology. Ma'am, we are truly honored to have you with us today. On behalf of iHera and Enronet, I extend a very warm welcome and invite you to deliver your talk. Over to you, ma'am.
Thank you so much. Good evening, everyone. Thank you for that wonderful, very generous reading of the CV. I think it's time to change it now. Well, I'm really delighted to be here for this session today, the webinar, because it covers such an important topic. As it is, we are talking about a field where it is mostly female dominated. And to begin a conversation about male fertility preservation is really something. And I need to congratulate iHera team and AndroNet especially for coming up with this wonderful series today. And with that, without wasting much time, I would like to begin. Only I would like to say that with a wonderful lecture now delivered by Dr. Dipankar, I really don't know whether I'm going to add too much to it, but then I'll try to do my best. I hope my slides are visible. Is it visible?
Yes, visible.
Okay, so we are talking about male fertility preservation in the era of delayed parenthood. A wonderful topic again to speak on, and really very timely topic. At the right time, we should give I mean, not ignore it and note it that we have to pay attention towards this. So as we all know that IVF is a predominantly female dominated area. Why female dominated? Because the cause of infertility, the investigation of infertility, the evaluation, the treatment, the result, pregnancy, everything just moves around the female. And poor chap, the male is ignored. So I wouldn't say the poor chap, because in many cases it is the other way around. The poor girl is made a victim even for no fault of hers. Why no fault of hers? Because we know that there are many instances, as good as 50% chances, where the male might as well be equally responsible for infertility, and yet no proper evaluation is done. So at such a time where even a proper semen analysis is often ignored, we are talking about fertility preservation in males. So that is very important, and let us understand why is it important. So why are couples or men especially delaying marriage in the present times? For education purpose, because they are want to go ahead in life, career, economic stability, lack of commitment, fear of responsibility. These are the basic things due to which now males are trying to delay marriages. At the same time, it is thought that marriage is down by about 60%, and men are the least likely to pursue it without financial stability or emotional maturity. And one more factor which we are not considering but which plays a major role is that men still want their life to live a life like their fathers did. That means they expect the wife to cook, to clean, to obey. But women have gone far ahead. They do not want to live a life that their mothers lived. They are now equal. They are studying. They want respect. They expect equal work. And therefore, there is this disparity in finding the right choice of partners. And this is the reason why, one of the major reasons also, apart from education, career, and all that, why men are delaying marriage, and how this is affecting the overall, what kind of cascading effect this is having on the overall fertility potential, we'll see in the next slides. So essentially, we are talking about this decline. When we talk of the need for fertility preservation in males, we all know how within our families, we have seen huge families, 8, 10, 12 children. I mean, the parents having, and then it came down to do bacche, two children in the family, then a single, and now out of choice, no children, but then at the same time, a couple having problems in conceiving. So the overall scenario, how the family structure, how it is changing, is very evident in our lifetime itself, from our parents, from our grandparents, parents, to us and the next generation. So what we are essentially also implying, that the biological clock is not just for women, and now the recent research hints that men's sperm quality also declines with age. So now, to understand it in the right perspective, as per the ART law, the minimum and maximum age for females to undergo ART is 21 years and 50 years respectively, while for males it is 21 and 55 years. So while the minimum age remains the same for male and the female, the maximum age for males is 5 years higher than that for female. So basically, it is implying that men are more fertile than females, at least for 5 more years, right? That is a general implication that we can draw from this. So, but then at the same time, it is believed that males have a longer and more sustained reproductive lifespan than females. Females are born with a finite number of eggs, whereas males continuously produce fresh sperm daily from puberty through the rest of their lives. So therefore, the general perception is that males are more fertile for a longer duration of time. They continue to produce sperm throughout their lifetime, and there is no specific time frame allotted for males. So the question arises then, does male fertility decline with age, now that we are talking about this topic? So this is data obtained from a UK data set, where it says that the standardized mean age for becoming a father is increasing over the years from 1980 to 2020. It has increased from about 28 and a half or 29 to about 35 years, right? So that is the mean age that you can see, that there is a rise in the age at which men choose to become fathers. And what is the live birth by age group? As you can see, these are different age brackets. Each colored line represents an age span from 25 to 29 years, 30 to 34 years, and so on. And this yellow line, at the bottom that you see, is 45 to 49 years of age. This is just above it is 43 to 44, and this orange is 35 to 39. So you can see how 25 and 30, from there is a drastic fall by the age of 39, and how it reduces drastically even further beyond the age of 40. So the myth that males remain competent throughout their lifespan, reproductive lifespan, or males have a bigger reproductive lifespan, turns out to be false or just a myth, because you see how there is a decline in the live birth rate, just about 10 births per 1,000 men reported in elderly men, right? So what does research say with respect to the reproductive axis aging and fertility in men? I have tried to take very recent papers. This is 2022 paper. So it says that male fertility does not abruptly end with age, but progressive hormonal, testicular, and sperm-related changes reduce the reproductive potential, and there is an increased offspring risk, making paternal age an important consideration in family planning. So what happens? Men remain potentially fertile throughout life, but fertility declines gradually with age. The hypothalamic pituitary testicular axis is affected. There is reduced libido. So what happens? The testosterone levels go down. The sexual functions also decline with age. And typically, the testosterone level declines by 1 to 2% per year after the age of 30. So see, that's a big percentage. After the age of 30 itself, 1 to 2% per year decline. So if the average age for becoming a parent, if it goes beyond 35, we are talking about more than 10 to 15% decline in the testosterone levels, and therefore fertility also. Then the problems with erectile dysfunction also increase commonly after the age of 40. Then declining Sertoli cell function and inhibin B production. And what does that essentially mean? It means that there is the sperm production is affected. And when we say sperm production is affected, eventually it has its effect, adverse effect on the volume, count, motility, as well as morphology. All of these go down once the Sertoli cell function and inhibin B productions reduces. And sperm production may continue, but the quality declines with age. So as I said, the volume, count, motility, morphology decreases. There is a high rate of DNA fragmentation, and there is a measurable decline as early as mid-30s. And along with that, there can be new genetic mutations, DNA methylation errors, and this, therefore, advanced paternal age or APA also eventually, because the quality of sperm is compromised as the male ages, it may also have an adverse effect on the offspring. So adverse, not only adverse pregnancy outcomes, miscarriages for the partner, but also the child that's born out of such sperm may have some genetic disorders. So I mean, it is a huge spectrum of a decline in sperm fertility potential that we are talking about. Then there is another paper which tried, it is a systematic review where they tried to correlate fertility and aging in the male. And because it was a review, they took into consideration all the papers that had been published, whether they were meta-analysis, case control, or cross-sectional studies. And they found that overall, there is reduced volume, count, concentration, motility, morphology, and vitality and DFI had not been studied in most of the cases. But then overall, there was a decline in the sperm parameters. So why does age affect male infertility or the male fertility? The main reason being oxidative stress. I mean, this paper emphasized that oxidative stress plays a major role. The reactive oxygen species damage sperm DNA and impair the sperm function. Also, there is an accumulation of new mutations. The stem cells divide continuously throughout life and accumulate mutations over time due to increased chances of DNA replication errors. We know that there are a DNA repair mechanism, but as the age advances, the repair mechanism is affected and the replication errors goes on increasing. And as the age increases, there is an accumulation of DNA replication errors, which brings about new mutations. And these new mutations are further responsible for affecting the fertility, not only of the male, but the child thus born also. Also, along with it, there could be epigenetic changes. So age alters DNA methylation patterns in sperm, affecting the genes involved in embryonic development, organ formation, and brain development. So it is a huge effect that we are talking about. So what is this DNA fragmentation or oxidative stress or epigenetic changes? So sperm DNA chromatin decondensation, right? And DNA fragmentation, reactive oxygen species, then it also causes, so aging results in DNA chromatin decondensation, DNA fragmentation, increase in ROS, therefore a mitochondrial dysfunction, and how it affects the DNA repair mechanism. So the entire genetic makeup of the sperm is affected because of this. And therefore, the natural pregnancy chances reduce and the chances of miscarriage increase. So advanced paternal age is linked to lower likelihood of natural conception, longer time to pregnancy, increased risk of miscarriage rates in partner, increased risk of autism, schizophrenia, and certain genetic disorders in the offspring. And mind you, these that we are talking about is not about the infertile male. We are talking about fertile males in normal males of advanced age. So you can understand what could be happening further if the male is has infertility problems as well. So age and infertility combined together may prove to be more detrimental. So obviously, therefore, if such a male comes for assisted reproduction, the fertilization rates decline, clinical pregnancy rates go lower, and there is the association of age with reproductive outcomes, obviously, and you cannot therefore rule out the effect of age, male age, on the results of assisted reproduction. So now, what are the causes? If we think about it, I mean, it applies globally. All over the world, there is a overall decline in male fertility. So one basic thing that we are ignoring, not keeping track of, is that what we, as is said, jaisa desh vaisa bhes, or when in Rome, behave as the Romans do. So as per our geographical location, we are supposed to wear certain clothes, eat certain foods, have certain kinds of drinks. So eat, drink, and wear as per geographical location. Why did our ancestors, our grandfathers, even our fathers wear dhoti, lungi, or loose pajamas, cotton shirts? Why did they have such things? Why was buttermilk more common? Why was sugarcane juice more common? Why was lemon juice more common in our country? And the kind of food that we have, which had a mix of everything. What we are doing, we are deviating away from what nature has told to do us as per our geographical location where we exist. And this applies, this I have shown for India, but this applies to every geographical location, because they have also changed what they used to do in they are supposed to do in their country, right? So that means lifestyle and environmental factors have a major role in how male fertility is affected. And of course, along with it, there is individual predisposition, and how can you prevent and take care of it. So this is a 2025 paper. Again, I mean, Tesarik's paper, which takes into account every possible aspect which could affect the male fertility. So declining male fertility is a multifactorial phenomena, and it is because of the lifestyle habits, environmental exposure, and individual biological susceptibility. And just like the earlier two papers, this paper also laid stress on oxidative stress, that one big factor leading to compromised semen parameters and male fertility is oxidative stress. So that is the central mechanism which leads to excessive production of ROS, which affects not only the sperm membrane. So the acrosome is affected, the mitochondria, the sperm DNA, and how it may also lead to impaired testicular function, spermatogenesis, abnormal semen quality, and therefore male infertility. So air pollution, endocrine disrupting chemicals, microplastics, heat exposure, like Dr. Dipankar just mentioned in his lecture, then the HPG axis disruption, and all this therefore leading to impaired cell cycle. And all these external factors together not only, affect the entire sperm, whether it is the head, midpiece, or tail. So this damage impairs the total sperm function or sperm potential. So, can lifestyle changes significantly improve male fertility? Again, this is a narrative review. It is a 2025 paper, and it tries to take into account the causes and pathophysiology of male fertility, where it says the lifestyle factors like diet and nutrition, the substance abuse, so the use of drugs, alcohol, smoking, nicotine, and all kinds of other drugs as well, stress and mental health, environmental factors, obesity, sexual habits. Promiscuity is on the rise. There is more stress rather than on marriage to have live-in relationship. So the sexual pattern has also changed. And most importantly, the sleep and circadian rhythm. So lifestyle choices have changed, and this has affected male reproductive health to a large extent. So these lifestyle factors, and of course environmental, then there are infection, various kinds of infection, inflammation, hormonal imbalance, epigenetic modifications, and the genetic and epigenetic factors. So all this together, smoking, excessive alcohol consumption, psychological stress, and most importantly, also sedentary lifestyle. So the food habits, increased weight, that is obesity, and so it's a vicious circle of sorts, that because of the sedentary lifestyle, because of lot of caffeine, coffee consumption, nicotine, and the kind of food that is eaten, so because of that, obesity is on the rise. And because there is obesity, again, all the more the lifestyle becomes more sedentary, because the person doesn't want to move or exercise. So all this is causing a vicious circle of sorts. So obesity, what does it do? It causes hormonal effects, lowers testosterone in inhibin B, and there is an increased conversion of testosterone to estrogen. So I need not tell what an effect it can have if testosterone is increasingly being converted to estrogen. So all this not only will affect spermatogenesis, not only will cause a reduced libido, but overall the male characteristics will go down, right? So apart from that, this can also cause epigenetic effects, the altered sperm DNA methylation patterns, and so on and so forth. And there is also something called as the potential transmission of mutations across generations, that is paternal transgenerational inheritance. So whatever lifestyle is being followed now, and what are its detrimental effects, they will be given to the next generation and generations to come. And this will cause a cascading effect of infertility among the males that are thus born, right? And poor diet, of course, will cause metabolic effects like insulin resistance, chronic low-grade inflammation, and of course, heat-induced alterations, because there is an increasing use of mobile phones, laptops, electronic devices. So there is an increased scrotal temperature and varicocele. So every single thing that we do, or the men do now in their day-to-day lives, is affecting their fertility potential. And this is this very recent paper, February 2026, which talks of environmental determinants of male infertility, emerging threats and technological interventions, where it talks about how the air pollutants affect the blood testis barrier, and there is therefore the altered function of LH, FSH, and decreased male fertility. Then it talks about the particulate matter, the carbon monoxide, sulfur dioxide, and so on, and how they are causing, resulting in increased production of ROS and oxidative stress. And this in turn causes lipid peroxidation, DNA damage, and mitochondrial dysfunction. And apart from that, there are also the occupational hazards where people working, whether it is the IT sector, where heat and stress causes the detrimental effect. Then if you are working in some other factory setup where there is heavy metals, so cadmium and lead are the major occupational hazards that can affect male fertility. And endocrine disrupting chemicals like phthalates and bisphenol A, etc., they are all contributing towards the decrease in the male fertility potential. And at the same time, when we talk of heat due to the use of laptops and mobiles and so on and so forth, we also have to take into consideration what is now globally a global phenomena, that is climate change, the global warming. This also affects male fertility. So the thermal fertility limit, see, there is a loss of survival of sperm and therefore reduction in fertility as the temperature increases. So climate change is also a major contributor towards male reduction in male fertility. And this particular study, it was this 2026 study where they took resort to very technological avenues to find out how this temperature can affect male fertility. So they used high resolution climate models, the multi-omics predictive framework, transcriptome wide association studies, genome wide association studies, and expression quantitative trait loci mapping. And they found that this identifies males at increased risk of heat-induced subfertility and guide personalized. And they say that personalized mitigation actions should be taken rapidly so that you can avoid this detrimental effect on the sperm. And of course, along with that, we all are seeing that post-COVID, there has been a decline in male fertility overall. There may not be too many papers, but then of course I did find 2 papers where the evaluation of the effects of COVID-19 on semen parameters and male infertility was studied. And again, a 2025 paper which said that poor sperm quality is a result of COVID-19 infection, where SARS-CoV-2 caused significant decrease in especially the sperm motility and morphology. And also that because of the COVID infection, there was an inflammatory response, and this inflammatory response is one of the leading mechanisms that may potentially explain the observed changes. And although there are other factors may also be involved, but inflammatory response is one of the leading mechanisms by which ROS and DNA damage is increasing to a larger extent. So, I mean, what we need to take into consideration, and Dr. Dipankar also mentioned about how we have this scenario of war also now. So in these countries, because of that, the impact of that on male infertility also will be enormous, and we cannot just ignore them. So along with the things that we do in our daily lives, our lifestyle, our job profiles, our occupational hazards, then environmental factors, the climate change, post-COVID decline, all these together are having such a comprehensive effect on male fertility. And of course, there is something called as a semen microbiome, where if there is an imbalance, so now taking too many probiotics without understanding how the semen microbiome works, that also may have a detrimental effect. So semen microbiome imbalance also changes the microbial community of semen and may therefore affect the sperm quality and fertility outcomes. So when we evaluate the sperm sample, we also need to understand what kind of infection is there and how to treat it, and what otherwise naturally what are the kind of things that need to be present so that the sperm functions properly. So if there is an imbalance of semen microbiome, that also may affect the fertility potential. And this is again in the recent times, because the use of over-the-counter drugs or probiotics to enhance health, this may be a major factor also contributing. And then finally, which is now a fad. So on the one hand, we have increase in obesity, sedentary lifestyle, and then suddenly there is this other class of males which are too conscious, health conscious, and lot of gymming activities, use of steroids. So all this also is affecting male fertility. So there is this again a recent paper 2023 and 2024 where one paper evaluated the use of anabolic androgenic steroids and male fertility. It's a systematic review and meta-analysis, and it is found that it is detrimental for sperm motility and has a partially reversible negative impact on male fertility, and users must be cautioned about its negative impact on libido and erectile function. So the increasing use of excessive gymming and use of steroids may adversely impact your not just the sperm parameters, but more so the libido and erectile function as well. Also, there was this paper that evaluated the gym lifestyle factors and male reproductive health, and it found that there is a significant lack of awareness and information surrounding the effect of gym lifestyle on male infertility in young adult population. And crucially, the levels of awareness differ significantly between men and women. So women are more conscious, are more aware. Men, in trying to get those six-pack abs and so on, they are more into this unscientific methods, and therefore it is affecting their health more. So this paper evaluated that the awareness levels between men and women is also different, and it is affecting. So men have a potentially alarming lack of concern over their own fertility, and how factors such as gym supplements can have a negative long-term effects. So in toto, everything that we do is adversely impacting our reproductive health, or in this particular case, we are talking about the male reproductive health. So how can you conserve in all this scenario when we are probably doing so many things wrong? what are the ways in which male fertility can be preserved? So there are three basic aspects of it. One is to use antioxidants. Second is to use hormone therapy, and third is the cryoprotectors. So antioxidants, as we all know. So now this again is a major problem, because what happens is when a couple, when we are talking of infertility, when we are talking of IVF centers, when the couple comes together, as mentioned, the focus is on the female, and more so if really the female has more problems, then just in order to give something to the male, a lot of antioxidants are prescribed to the males. Again, that is a wrong practice. So a proper evaluation of the semen parameters, semen quality, and then prescribing antioxidants also is one way in which you can preserve. Otherwise, just empirically providing antioxidants can also be harmful, right? So as I said, you have to maintain not only the microbiome balance, but also the redox balance needs to be maintained. If you unnecessarily give antioxidants also, that may hamper the fertility. So antioxidants nevertheless is one way in which to preserve fertility. Hormone therapy, that is to give testosterone, etc., GnRH agonists, etc., and cryoprotectors. So what is testicular aging, and is it possible to reverse or prevent these changes using endocrine therapies? So one of the major hormone therapies, just like we talk of HRT in females, there is something called as testosterone replacement therapy for males. And can it reduce fertility? I mean, the question is it really, is testosterone replacement therapy really helping, or does it reduce fertility? And if it really is reducing fertility, why is it doing so? So what again we need to be cautious about? So external testosterone suppresses LH and FSH production, which are necessary for sperm production. Therefore, providing TRT may improve symptoms of low testosterone. So if the testosterone levels are low, giving testosterone supplementation may improve the symptoms, that means may increase testosterone levels, but then in turn, because in doing so it is also suppressing LH and FSH production, therefore it may worsen or stop spermatogenesis. So when to give testosterone replacement therapy, how much to give and how to give is again very important if we are trying to conserve the fertility of males. So men who are actively trying to conceive should generally avoid testosterone treatment unless carefully managed by fertility specialists. So just like antioxidants providing empirically, similarly providing testosterone gel without understanding what could be its long-term effects. I mean, short-term you are trying to increase the testosterone levels, but just increasing testosterone may not increase the Sertoli cell or function or spermatogenesis or sperm production per se. So again, testosterone replacement therapy as a way of conserving fertility in males is a lot to be studied and looked into before we really apply it in a proper manner. So greater awareness of male reproductive aging is needed in fertility counseling and reproductive medicine. So this is one important observation, that when we talk of fertility, focus is on females, our focus is on premature ovarian insufficiency, poor ovarian response, and therefore donor oocytes and oocyte cryopreservation and so on and so forth, and a lot of counseling goes into it. But to understand male fertility also, just even beyond semen analysis, and to give a proper counseling to the males as well regarding their own lifestyle, the day-to-day habits that they are following, and to make them aware of how not just give a general counseling about smoking and alcohol and so on, but also if they are into use of such testosterone, use of testosterone gels and so on, we need to be really cautious and caution them regarding the use of such things. Then to treat infections, of course, you can conserve fertility of males by treating infections. So first we need to really find out what is the kind of infection present, what is the kind of inflammation, and therefore what kind of medication is to be provided. also to manage erectile dysfunction, correction of hormonal abnormalities, and giving antioxidants like L-carnitine, omega-3 fatty acids, vitamin C and E. All these may improve the semen parameters, but then evidence for improving pregnancy rates is less convincing. Because, see, why is it less convincing? Because if we don't understand how it works and how much to give, we may cause more harm in the long run. I mean, for a short-term benefit, just to increase some levels for the time being, we may cause a greater harm. So all these fertility preservation tactics are less convincing, and therefore we need to be wary about it. And of course, there can be varicocele repair, because varicocele become more common with age and are a reversible cause of infertility, and surgical repair may improve sperm production in selected male. So wherever males have varicocele, a surgery can be attempted to repair and to restore sperm production. So these are the kind of male fertility preservation tactics that can be used with caution. And therefore, we can say that male infertility is increasingly recognized as a significant global health concern, with lifestyle factors being critical contributors to the declining male fertility rates. So it's not just the females. We are talking about a furnace, literally, the hot air that is contributing to the reduction in fertility. So we are literally sitting on a hot furnace regarding the male fertility. If we don't really take care now, it can have long-term effects. And I just skipped keeping that slide. The WHO guidelines itself, how over the years there is a decline in the normal sperm count, tells us what kind of a decline we have had. So I need not go into it. All of you all are aware of how the sperm parameters have declined over a period of time. So it is alarming unless we really take care and take notice now. So there is not just the female biological clock, the male biological clock is also ticking. It may be slower, but then it does happen. So don't take it for granted that males remain fertile. Their reproductive lifespan is as long as they live and they are active. No, it is not so. The male biological clock is really ticking, and we really need to take care. So it's a myth that only women we need to focus only on women. All the research that has been mentioned up till now, they tell us a very nuanced story about how the male biological clock is also ticking. So male fertility after 35 does change, even if it doesn't come with the age cutoffs often associated with female reproductive aging. So obviously there is a difference in the kind of aging that a female shows and what the male shows, but then make no mistake that the male fertility clock is also ticking, and we have to preserve fertility. So male reproductive aging is really and clinically important, and better education is needed for clinicians and prospective fathers. So males need to understand, and the clinicians treating them or the IVF specialists also need to understand how they have to focus on the male partner as well when they come for treatment. So at present, there is no established intervention to eliminate the age-related sperm risk. Like I discussed, that antioxidants and hormone replacement therapy may have its own side effects or ill effects. So what remains, therefore, is the cryopreservation. Now, again, as there is this myth about only female biological clock ticking. Similarly, there is this myth about cryopreservation needed only for patients, onco-fertility patients, or people undergoing some treatment with steroids and all, or for cancer. No, you can do cryopreservation, a normal cryopreservation protocol or a technique for preserving fertility in males. It need not be a male factor, severe male factor, and obviously not for oncofertility preservation. A simple cryopreservation of sperm for fertility preservation is the need of the hour. So semen cryopreservation or sperm banking is a very simple procedure. It just involves a collection of sperm via ejaculation, followed by freezing and long-term storage. So it's a very simple procedure compared to the oocyte cryopreservation. Sperm cryopreservation is a very relatively easy procedure. And this paper again tries to evaluate the fertility preservation indications and available options for adult non-cancer individuals. So I tried to find out some research related to fertility preservation in males for non-oncology factors. And this is only one paper that I could find out, where it says that for men, sperm retrieved from ejaculate or surgical intervention of epidermis and testis have long been successfully cryopreserved. Outcome of fresh or cryopreserved sperm are similar. So males need not be wary about what the results would be if the sperm is cryopreserved, whether they would be able to fertilize or not. So yes, the potential remains similar. Indication of fertility preservation depends on medical or genetic condition, personal preference, career requirement, or apprehensible risk of damage to gametes. And sperm cryopreservation is a well-established procedure and much more easy than oocyte cryopreservation. Cryopreserved sperm can be stored indefinitely. And as far as literature goes, a cryopreserved sperm sample has been used successfully even after 40 years in storage. And post-thaw survival rates are more than 50%. Now, why 50%? When we, in terms of oocyte cryopreservation, we are talking about more than 90 or more than 95% cryo survival rates. Why post-thaw survival rates? We are talking about only more than 50%, because one, that we are talking of millions of sperm. So not all will they might survive, but there is motility is hampered, right? So post-thaw overall survival rate, good sperm survival rate is more than 50%. That is a very conservative percentage that we are giving. We may have a good post-thaw survival rates and good fertility potential use for IVF as well, but then more than 50% is the post-thaw survival rate. And therefore, to end, I would just say, I would request all people associated with the field of IVF, IUI, or assisted reproduction that give more emphasis on the male partner as well, even if the male may not be, compromised. There may not be any subfertility, male subfertility, but then make them aware that the sperm cryopreservation is a good option to preserve fertility. Not just for them, they can spread the message. So that is one way where we can spread awareness and message to all people. So not just public awareness fora, we can have social fora on which this message can be spread, but also to our patients who are coming, to spread this message among their friends as well, that if they have friends who are not married, who are delaying marriage or delaying parenthood, they need to freeze the sperm while it is still time, while they are still active, so that the progeny that is so produced also becomes healthy. So we are not just talking about a healthy male, we are talking about a healthy offspring and good offsprings for generations to come. For that, we need to focus not just on the female, but the males also. Both gametes are equally important. So freeze them and rest assured, freeze the sperm today, so tomorrow's dream of parenthood remains within reach and it doesn't become a very difficult proposition for everyone. So thank you. With that, I would just like to say that let not the swing be topsy-turvy in opposite direction. Let the male and female swing together and look at fertility in a similar manner, rather than one, focusing only on one partner. Let us focus on both the male and female and talk about fertility preservation for everyone. Thank you so much.
Thank you very much, Dr. Bindu, for the excellent and insightful presentation. Your talk beautifully highlighted the importance of the fertility preservation in today's changing social landscape and provided valuable scientific insight into an area of growing relevance. So we sincerely appreciate you for sharing your expertise and experience with all of us. I would like now, so we are moving towards, like, as we are lacking the time, we'll now move towards to the panel discussion. So we are concluding here our second scientific session. Over to you, Jay, sir.
Thank you so much.
Yeah, thank you, Priyal. Thank you, Dr. Bindu Chimote ma'am, for the session. So moving on, I welcome you all again for the panel discussion. First, I would like to introduce Dr. Akash Agarwal, who is ESHRE certified clinical embryologist, has been serving as a management committee member for ACE, has been a member for the IFS, and is also a guest faculty as assistant professor at ASPA University. The second moderator is Dr. Chirag Gupta, who is uroandrologist and microsurgeon at Bombay Hospital, Jaipur, and has special interest in male infertility and male sexual health, and has various publications in various national and international journals. With this, I would like to invite our panelist, Dr. Rajvi Mehta. I'm sure she needs no introduction. She is well reputed and renowned. I welcome Dr. Stuart Long, who is a lead clinical scientist in andrology in the Liverpool John Moores University. I welcome Dr. Sanjay Deshpande, who is the past chairperson with CSEPI since 2017, and is the Honorable Secretary at Indian Andropause Society. Dr. Devin Patel is our next panelist, who is the Chief Embryologist at Sunflower Women's Hospital, and has been awarded Hall of Fame Embryology for West Zone by ET Healthcare, and has been working in this field for more than 20 decades now. I welcome Dr. Deepesh Soratia, who is director and founder at Khushi IVF at Ahmedabad and Ajmer, and he's heading the IVF department at KD Hospital, Ahmedabad. We have Dr. Kapil Kochar next, who is andrologist and microsurgeon from Indore. He's trained in andrology and microsurgery and working since 2001. He has publications in various journals and has been awardee of ISA Dronacharya Award. I welcome you, Doctor. Next, we have Dr. Rudri Agarwal, who is MBBS, MS, DNB, FMS with fellowship in reproductive medicine and fellowship in general reconstructive surgeries, and has been a gold medalist in that. And she has been a member of she has been member of FOXY and active member of HISTRY and ASRM. Next, we have Siddharth Modwadia, whom we have introduced beforehand. He's a senior embryologist working for a long time now. And with this, without any more further delay, because we are running really short of time, I would like to hand over this session to our moderators.
Thank you, Jesh, for the kind introduction for me, my co-moderator, and all the panelists. I welcome all the panelists to what we hope is going to be a slightly offbeat session as far as embryology is concerned. So thanks, Vitsa, for sharing this one. So we had two wonderful sessions about the declining male fertility and about the cryopreservation and how it can help as such. So we as embryologists, majority of the time see someone, say once they come with the semen analysis, or an occasional patient who has difficulty in having a semen production as such in giving a sample. So, but men's reproduction health, is it limited only to just a semen sample collection? And if not, then a surgical sperm retrieval? Or is it something beyond it? So we are going to see the various different angles, perspectives about this. And we would start with Dr. Kapil. Would you like to take the question first? Dr. Kapil, you're there?
Yeah, I'm there, yes. Yes, when we talk about men's reproductive health, it definitely encompasses much beyond fertility. Fertility is just a small part of it. When we talk about reproductive health, it starts right from the birth of the child, goes up to the man departs from this world, and covers all the aspects of the developmental aspect of the health, and then goes on to the andropause, and later on in the geriatric age group, the requirements are different, and it goes beyond fertility to also looking after the sexual health of the male. So definitely it is not only this, but this also is connected with the mental health of the male, also the psychological aspect of the male. So overall, it affects the emotional aspect of the person. So every aspect of men is covered under male reproductive health.
Okay.
The male reproductive health, what I feel is the fertility plus the sexual health, and how long they are in contact. So that's what I feel the reproductive health means, and the sexual health is very important because I have gone with many couples who are having unconsummated marriage since many years, and for the simple reason that the male is having just a phimosis, and that phimosis led untreated relationship, and this lead to unconsummated marriage and infertility.
One suggestion from my side also, being a sexologist practicing since last 23 years, I think reproductive health is inclusive of sexual health.
Yeah.
Sexual health or sexuality is a very broad spectrum. What earlier urologist Dr. Kapil said and what you said, that lot other aspects like emotions, relationships, myths, beliefs. So sexual health encompasses even reproduction also. And that's why we should give more emphasis on sexual health per se, so that every aspect can be covered.
True.
Okay.
Right, sir. Dr. Rudri, can we have your views as someone who is practicing infertility more more towards ops and gynae side?
So very rightly said by Kapil sir and every other panelist that other than infertility, the men's reproductive health extend much beyond that. Starting from the sexual life and the social marital life also it affects. So it does not relate to infertility only. Rather, it's a day-to-day social life also for a man when we talk about the reproductive health. So definitely we should be, when we treat a person with a male, particularly in terms of infertility, we should also look and we should also try to give a holistic treatment rather than just to treat infertility. We have to look at all other parameters also. So that's my view. Yeah.
But do we in infertility clinics as such give importance? I mean, a frank opinion about what we actually do when we are practicing purely in terms of infertility. Do we actually think and actively take part towards that side, or we are more concerned about the semen as such and the sperms rather than the reproductive health?
So
definitely, when we counsel the patient and the couple tells us that they are suffering from infertility, so our primary focus definitely is to treat the infertility. But on the other hand, we also try to counsel the patient that other than infertility, there is much more. So if the patient is not satisfied with the sexual life, we always try to counsel them, and we try to take that issue also, not only infertility. Yes, it's a holistic approach always.
Okay.
Definitely. When the patient comes sometimes of unconsummated marriages and they are just looking forward for having a baby somehow, I always counsel them that that is secondary. That has to be secondary. That cannot be the primary aim of treatment. And we first focus it on the cause of unconsummated marriage and try to work on it first. You correct that first and then go even for ART if required.
Okay. Stuart, you want to add anything over here?
Yeah, so from my perspective, we do see a lot of patients. I mean, we've got a specialist clinic, so we support from a psychosexual perspective, where we link in with urology to try to support patients that do struggle. We see so many people who are referred to us where it looks like infertility. It may be infertility, but actually there's something else going on far, far deeper. You know, there's people who have childhood traumas that impact their sexual function, that on the surface, there's a lot of people that will go past that because our focus is often on where's their semen sample, if they can produce one. And I mean, we do often assume that they've also had the opportunity to produce a semen sample. There may be something else going on that prevents it. So I think absolutely, in terms of where we think in infertility, we've got to look further back. We've got to look at that couple, and we've got to consider how we will support them in achieving their goals. And that can very, very often be, how do we improve their sex life? How do we improve their health and well-being as a couple? And sometimes as individuals, sometimes their issues are because of the relationship. And I think it's really important that we consider how they can enjoy that as a couple, a healthy sexual relationship.
Okay. So I just would want to add a bit more on this in terms of anybody has a differing opinion. See, when a patient says, say it's a case of unconsummated marriage, then there's obviously pointing towards a sexual health problem as well. That's an obvious indicator. But does Dr. Sanjay has to add anything different where he had patients who were like, has he seen patients where they had undergone infertility treatment and whether sexual aspect was neglected or not? As there had in his experience, in his vast experience, has he seen this kind of patients, and how commonly is it? How common is it?
Yeah, very nice question. In fact, I have seen one couple. I just want to tell you here. The couple was married for 20 years and then came to me. They were relative of a medical representative. And after taking history and all, what I found was it was non-consummation of marriage. So non-consummation of marriage is very common, as we suspect, and there was no cause. The wife was not having any vaginismus, or her husband was not having any problem. Only problem was, which is very common in our practice, that is not knowing the exact anatomy of a female sexual organs. So not knowing the position, sexual positions, they used to ejaculate only outside vagina. So after taking the detailed history, we found that, man, because when we asked history, are you doing sex? Okay, everything was okay. Semen analysis was okay. My semen also gets ejaculated. Then after thorough history, when I probed that case, then I found that he is ejaculating outside the vagina because of non-consummation of marriage. And the reason was not knowing the position of sexual intercourse. So many times when young married couple comes to us from infertility experts because they are referred to us, then we ensure that exact sexual intercourse is taking place or not. I ask the three simple questions to them, that whether the penis gets erect, whether the penis goes inside the vagina, and whether the ejaculation goes inside the vagina or not. So these are the three basic questions I think everybody of us must ask to avoid this or to miss this.
Okay, thank you, sir. To Dr. Kapil, back to you. Yeah, you want to add something?
Yeah,
please.
I had seen a patient. I distinctly remember an engineer husband and a teacher wife coming from an urban background who had 6 years of infertility, and the cause were they were having anal intercourse. So for 6 years, they had anal intercourse. Correction of that led to pregnancy within 3 months. So sometimes simple solutions to complicated problems.
Yeah.
Dr. Chirag, you want to ask anything further?
No. Please continue.
We'll move to the next question.
Yeah. Please move.
Yeah. Sir, next slide, please. Yes, sir. Sir, can you take the next question, Chirag, sir?
Yes. So now we are going to discuss this case, which is showing that the male is around 28 years old and they are married since last 3 years. Wife is 25. and the semen analysis comes out to be a nil sperm, that is azoospermia. Now patient comes to the clinician, and they want to ask then what to do now. So how do we should proceed? I will like to ask this question to the uroenterologist who is in our team. Kapil, Akash ji, who is the
Yeah,
uro?
Dr. Kapil is there with us.
Dr. Kapil sir, can you take this
Sir.
question?
Yeah, sure.
Yes, sir. So,
well, when a patient comes with the report of azoospermia, we start with again just like a normal patient with history. And I always ask them what was the abstinence period? Did he have a good erection? Was he able to ejaculate properly? Was in a proper mood? Did he spill the sample? What is the volume of the sample? So these are some simple things we ask because many a times it's a technical error. He may not be azo, he may be having some count, but then he has spilled the sample and then the result comes as azo, or it is a transient azoospermia which is result of certain medications he has been taking, or there has been some other issues. So all this first we rule out. And once we have done that, then we go ahead and ask him about all the history, and then we do the examination of the patient. And then we look at the testes, the volume of the testes, presence absent of vas, this epididymis, whether it is full or it is not to be palpated easily. So based on this, then we move ahead and form a we come to a conclusion as to what is the cause of azoospermia. So every patient who comes with azoospermia may not be having actually an azoospermia. It may not be a proper azoospermia. It may just be a transient one. So we need to rule out that, and then we need to move forwards and take a proper history and go in for a detailed history, go in for an examination, see the volume of the testes, see whether the vas is present or not, the consistency of the testes, and based on that, then we decide whether it's an obstructive azoospermia or a non-obstructive azoospermia, and accordingly we move forwards.
Okay, so I distinctly remember that I have seen two patients with some history and examination showing a very different scenario which we see in our OPDs. Like one was having absent vas on one side and another side was operated for hernia. So he came with azoospermia, but not untreated, not treatable surgically, and another patient was having obstruction on the left side, but right side was atrophied. So in these type of examinations and history helps because sometimes hernia and hydrocele surgery leads to obstructive azoospermia. Next slide. So the semen analysis again is a very important report, which sometimes comes to a very from a very bad lab. Akash, can you change the slide?
So next slide, can we have the next slide?
So sometimes in our setup, we see semen analysis done by a very
so I'll
bad
just
lab.
read out the slide. It's not changing. So it's the semen analysis report. Like say we have a patient of azoospermia.
So they have done this.
Come
so they have done this semen analysis in a way that like they are doing urine analysis. Actually, they have seen pus cells, RBCs, epithelial cells, like they are doing a urine test. So these type of labs we cannot rely over it. We have to repeat the test from an authentic lab who is doing properly pH, fructose, and get a good report which shows agglutinations and liquefaction time, the volume, abstinence, everything should be mentioned over there. And the transportation is again very important. Sometimes patient takes sample at home and carry it in ice pack, sometimes with a ice pack, and this leads to a wrong report. Sometimes he puts the operator puts the sample in front of AC vent, and this gives again a wrong report. So these things we can make out through a repeat sample or a good lab after a week or two. Can somebody change the slide?
Yeah.
So this is a good report which mentions majority of the things which we need. As we see the motility, its kind of motility, its volume, pH, everything, color, liquefaction, viscosity. So these type of reports are good reports. So again, if it comes to this thing, azoospermia, then we have to look at the fructose and the examination finding, as sir said, Kapil sir said. Yeah.
Yeah. So
Tell
a
me.
question to the embryologist. What
Right,
would,
sir.
yeah, Rajvi ma'am also has raised a hand and Dr. Devin. Yeah. So what would you like to add in this test? What are the things which you would like to concentrate on a semen analysis, say when you're
I
not
think
finding a sperm?
So in this particular one itself, even this semen report I would do, because you are reporting sperm count per ml. Now that means the fundamental something's gone wrong, because it will be concentration is number of sperms per ml, count is the total number of sperms in the ejaculate. So I think that also needs to be very clear. I mean, it could be a typographical error or whatever it is, but then it starts I would start questioning the lab itself, which is because the fundamentals are not clear. So I think that's the first thing. Yeah, we talk about the WHO manual and even the previous slide, I mean, azoospermia, I feel, is the most difficult to put it down on paper. It's very easy to run through a slide and run through some fields and then state that there are no sperms and say azoospermia, and that's the end of it. But in reality, I think one has to be extremely cautious before labeling it. So like, you really need to centrifuge the sample, and I would say look through the entire, even if there are few sperms and this patient gets pregnant, then you are in deep trouble and the wife is in deep trouble or the partner is going to be in deep trouble. So I think we need to be very, very cautious on reporting azoospermia. So I think that's although it appears technically simple to report azoospermia, I think it's a big responsibility and one has to be really cautious about it. So that's my comment. Yeah, I think Devan wants to say something.
Yeah. So I think correct. We also do the same thing. Like we see the whole sample, we centrifuge, and then I see whole sample, complete palette. And again, we ask for the second sample, maybe in an hour or two. And again, we do the same thing, do a palette, and then check the whole sample, not the part of the sample. So that is one thing. And second thing, just everything is covered, but still, I would like to add one thing as an embryologist. Every lab embryologist or andrologist should explain to the patient how to collect, and proper instructions should be there, or at least that should be pasted in the local language and at least in English into the collection room also. So after explaining, there should be some instruction also how to collect the semen.
Right. Siddharth, you want to add anything?
Almost all points are covered by Dr. Rajiv and Devin sir, but I agree with both of them, and most importantly, as Devin sir said, the collection way. Many times the when the patient will ejaculate the sample, the front part of the ejaculate is it goes outside the container. So in those kind of samples also this misanalysis can happen. So that is one of the important point we should be careful about.
We have got a system. We always have a seal when the patient comes out of the lab. We ask the patient to sign a sign. We have there that yes, the abstinence was proper, and then the time of the ejaculation is written, and then it is also written that no sample the sample did not spill, or was it spilled. So he has to fill it so that we are doubly sure of things. I have also started telling the lab people to take photographs, because we have found out 3 patients in the recent past who sent their friend inside for a sample. And then the report was wrong. I mean, so we have to be very sure of things.
Dr. Kapil, this was exactly what was running through my mind when you said you have a sort of checklist of things to be done. How do you ensure? I mean, I know this is not exactly a part of reproductive health as such, but it's a part of human nature where people may tend to hide the problem, may not be ready to accept the problem.
Yes.
So I would like to have views of Stuart as well as Dr. Sanjay on this.
Yeah.
Thanks. Oh, sorry. Go ahead, Sanjay.
No, sir. You can go ahead. I will talk later on. Please.
Thank you. So I was going to say, I'm an andrologist as well. So my points would be absolutely, I think azoospermia is incredibly difficult. We never say azoospermia, we say suspected azoospermia. And also as part of it, we don't centrifuge, we use large volume fixed depth chambers because they tend to be more sensitive in trying to identify sperm. The other thing I would say is that what we've got into the practice, I've not quite taken photographs just yet, although we probably should think about it. We do ask them health questions. I think it's really, really important that we understand how, as scientists, we interpret the laboratory results. And yes, they will follow with consultations, of course they will. But what we don't want to do is put people on a management pathway that could have been identified a lot sooner. You know, if they have, you know, come off anabolic steroids, as was mentioned with the last talk, if they've had a really severe illness, such as if they've had sepsis in a hospital, we know that that will reduce their semen parameters and their semen quality to such a level, it's at least going to be severe oligozoospermia. So I think it's really good practice to bring in holistically what's going on with that patient at the time of ejaculation.
Okay. Dr. Sanjay?
Yeah, actually, yesterday only one patient came to me. The patient was, he came 3-4 days back to me, and then he was having phimosis. He was 40 years old, and he told me that he is not married, but he has a phimosis and he wants to marry. So he wants to get the phimosis surgically operated. So I sent him to one of our senior surgeons from Nagpur. After going to that surgeon, what he said was, it's quite interesting, that's why I'm telling it, that he said, doctor, after doing the phimosis, will my parameters or my semen parameters will change? They ask in their vernacular language, मेरा सीमेन पतला तो नहीं हो जाएगा या उसमें खराबी तो नहीं आ जाएगी. So our senior surgeon got suspicious. He said, now what we'll do, we'll first do your semen analysis, and then so that you are sure that there is no change. He sent him to semen analysis, and he was azoospermic.
Oh.
So sometimes patients, they play with you, they want to trap you. After phimosis, he would have done semen analysis, he would have said that because of your operation, of course, there is no rational in that, but look at how patient they behave. So this was just yesterday's example. But another thing is that what Dr. Kapil said, it happens many times because of some legal issues or divorce issues pending in court. And if a person knows that his semen parameters are abnormal or less or azoospermia, by his name, he may send a person whose semen parameters are normal. And that's why sometimes, yesterday only I feel that we should check the Aadhaar card of the patient, whether the same name is there or not. Because it happens. Impersonification may happen. Many times in our sexology practice, patient doesn't reveal their real name also. So that is a real concern. Whenever we are doing semen analysis, Dr. Kapil's experience also says the same thing. We should see the Aadhaar card of the patient.
It's actually quite an issue because they go to one lab and they know it's an azoospermia, and then they'll go to another lab. They'll say collect it at home, which nowadays most ART clinics wouldn't want it. But then they'll get somebody else, like you said, and then it's become a big problem. I mean, finally, the clinic has done a mix-up or anything may turn up. So,
another problem is to identify the right person from the Aadhaar card photo also. That itself is a big challenge many a times.
Yes, that's true.
We have seen patients like this who try to impersonify. So before I would share my experience, I would like Dr. Rudri whether she had any experience of this sort and what was done to handle this. Dr. Rudri?
Yes, Dr. Akash. So, yeah, everything has been covered very beautifully, but I just want to add some of, few things that, we also look at the history. Probably there could be any history of chronic disease into the patient, or maybe he is suffering from chronic stress since last few months. So that history also needs to be taken care of. That's what I want to add it to.
Okay. I think we'll move to the next slides from here. Dr. Chirag, you want to take further?
Yes.
Yeah.
So, for this kind of situation, now we will move ahead towards what is the cause of azoospermia in this case. So, some clues which a semen analysis gives us is the volume. Volume is either low or high, um, less than 1 ml and more than 1 ml. If it is less than 1 ml, it shows that there is some distal obstruction like CBAVD, ejaculatory duct obstruction, or there is some ejaculatory dysfunction, retrograde ejaculation or anejaculation. Low volume means a obstructive or a ejaculatory dysfunction, but high volume doesn't mean it is primarily a testicular failure only, because it can be a obstructive azoospermia also by blockage at the level of vasoepididymal junction or at the level of so you say vas. Because if there is an epididymal blockage or a vasal blockage, the volume will be good, or it is a hypo kind of situation. So in this case, now we will go ahead with the blood tests of like hormonal tests. And in hormonal tests, that will suggest us some more clues of azoospermia, like it is obstructive or non-obstructive. Then, if there is a vasal absence, then bilateral absence, we will go ahead with the CFTR gene mutation. And if there is a primary testicular failure kind of scenario, we will go ahead with the karyotyping as well as YQ microdeletion, and like that we will go ahead.
The next slides. So I think with this we'll end the question, which is for the first one, which was based on azoospermia, and we'll take on the next question, which is the second case scenario.
So in this case, we some of the times we face in our OPD that the patient is quite young and he is having some malignancy. With that malignancy, he has been operated and now they are planning for chemo and radiotherapy. Now the oncologist wants semen sample to freeze beforehand for the fertility. And now he comes to the embryologist to get his semen sample freezed. So how to approach this case? Akash, who can take this case?
Yeah. So we'll start with first, let's say it has been sent to an embryologist directly, oncologist has referred, comes to a infertility clinic, obviously majority of the times, comes to the reception desk, they are like, okay, no infertility as such, just for, as of now, it's for semen freezing, collect a sample. And many a times patient doesn't want a consultation also with the infertility specialist as such. So they'll be referred straight to the lab. So I would say start with Dr. Devin. So you have seen a patient like this, young 16-year-old boy suffering from cancer, sent for semen freezing. So how do you proceed from here?
So first, obviously, we will ask the patient, like we will explain, we want the semen to be frozen. So obviously he need to do the semen collection by masturbation. So maybe if he is not able to understand, maybe we need to explain that how it is to be done. So I think we need to basically we need to explain him that for freezing semen freezing, the masturbation is very much important, and then only you can ejaculate and give it. So sometimes this kind of patients, because he is very young, they are more confused. Like maybe he might not have even tried, and then they are really confused. So I think this is little kind of difficult kind of cases.
Okay. Dr. Dipesh? Dr. Dipesh, you are here?
Dr. Dipesh is not there. Actually,
Not
he's
there?
busy in
Okay.
surgery.
Okay. So I would like, Stuart, you want to add anything? How difficult it might get to explain a male patient, young male patient. So what do you do practically? I mean, like Dr. Devan said, you have to put them up for explaining how to masturbate, but how difficult is it in that kind of a situation? And what do you do?
We do, yeah, I mean, we see young people as young as 13. As long as they've started puberty, we will see them, and we have a huge demographic where we have to have translators to support those consultations, so that can be quite tricky to try to actually approach it in a sensitive way. Now, we do ask the referrers to initiate a conversation with the person that they're going to send to us, because we think it's a bit of a shock if they arrive at the lab and suddenly they're given the information that they're going to need to masturbate, what that means for them. And, you know, it's already a really difficult time for these young people. They've got cancer, they're going to be worried. The parents are probably not helping. They're probably doing their very best, but everyone is going to be very stressed. There's going to be a huge amount of pressure for a young person to produce their sample. We give them extra time, so we talk to them. We make sure that they're given enough time to ask questions. We also ensure that we follow any safeguarding processes, so we make sure that they're safe, that they understand what they're doing and the consequences of what they're doing. In the UK, we of course, we get people to reconsent to storage every 10 years. So at least we can come back and revisit those young people. But yes, for us, we make sure we have counselling skills. We all get trained in that. We try to support those young people. We give them enough time. We give them an environment which is not noisy, which is away from other areas. And then we try and be flexible with them. It's a really, really difficult area. And we've just got to go, each person we take as that individual. We do with anyone, but for young people, we will treat them as they need to be treated when they visit the service.
Definitely, it is a very difficult situation where the young guy who has not masturbated yet any time in his lifetime, we need to teach him how to masturbate it and how to produce the sample. He has never masturbated. He is in trauma of being at a verge of cancer, something which is very serious. He doesn't understand. And now they are planning something which is called very toxic medications, which are going through his body. And he doesn't know the future. What is the future? How long he is going to live? So this is a very difficult. And in this case, we can take help of vibrators. Different type of vibrators are available in the market, and I have few with me. Some is from India and some is from abroad, like Vibract and all. And in these cases, we can take help of electroejaculation also, and those are done with under general anesthesia at a certain selected centers. And somebody else wants to take the question, how they want to approach it.
I would like to ask individually embryologists as well, Dr. Rajvi first, like, no, it's so much difficult facing these patients. I know it's a challenge, you know, sitting over there for any chemo patient, for any cancer patient as such, forget about a young boy. So what safeguards do you think, is it worth explaining to them regarding what are the uses of sperm freezing and everything? Is it possible in an Indian scenario? What Stuart was saying in a westernized scenario, yes, but in an Indian scenario.
I think in this kind of a case, it's also the parents, because, you know, everybody's first thing, the cancer, the C word creates a big shock. So, you know, the immediate mind is how long are you going to live? That's the mindset, although oncology treatments have changed. And here the person is still like a kid, you know, the physiological aspects is one thing. I think it is important to tell them what the consequences could be, what it is. Even if it takes time to explain. And I know it's a big challenge because even in the oncology, we know how crowded they are. So it is very difficult for people to give time to counsel them. I talk about fertility. So it's always sent off to the labs and the cryopreservation centers, mainly the IVF clinics. So I think it is important to explain. It is time consuming. We don't know how much they'll gather, unlike our infertile couples who are so well read and know everything that's going to be done. It is challenging, but I think we need to, so they know what they're going in for. One sample, two samples, obviously, and the prognosis, because we really have no idea about the person reproductively at all. We have no analysis done ever. Obviously, we don't know anything. So I think these kind of cases are challenging on the emotional front, the counseling front, the physiological collection, and talking to the couple, to the parents, about the person. So the child is 16-year-old, so it's not even an adult. So I think, but in my mind, yes, we should explain everything. How much they register, I don't know, but we will need to.
I wanted to add something. Means right now we are talking about counseling and explaining the person about the collection, about the uses of the semen freezing, about the future of the how semen will be frozen, everything, how the collection should be done. But the point I am putting is he should be also be suggested for the psychological counseling before doing this. Because right now, if I see many IVF centers are having psychological counselors also. So in this kind of cases, if patient goes first to the psychological counselor and then comes to an embryology lab, then it would be way better for them and even for us, both the sides. So this could be a simpler option.
I totally agree with you, Siddharth. I think we are not geared to counsel these patients.
Yeah,
Exactly.
Yeah, we don't have the exact tools when it comes to handling a complicated, complex case, I would say, where they require many things go on. Like it was said earlier also, I had a patient who was asking, do I need it? I don't know how long will I live. So we don't have an answer to that. I mean, fertility is the last thing which is passing through my mind. This is someone, he was somewhere around 18, 19 years who has told me. And then it becomes very difficult. It becomes very, I mean, you can't say yes, you can't say no. And if we have a slight change, I faced a similar situation. Can we have a slight change, please? Next two slides. Another next. Yeah. And the report has come as azoospermia. Imagine this. I actually faced this. The patient was having a testicular CA and it has come. Then what do you do? I mean, how difficult it becomes to say a patient who had difficulty collecting and why to collect. And that now comes as azoospermia. So what should be the approach now? What should be done next?
No, like Siddharth said, I would first definitely say that we need a proper counselor who knows about the mind of an individual, So that I think is very, very crucial, and get them, because, they are seeing a near-death situation. And this adds on because, the cryopreservation is some hope of life. And an azoospermia diagnosis possibly kills that hope, at least momentarily. And in your case, at least, Akash, that patient did not want to cryopreserve. But there are people who come with the hope, and then it's still worse. So I don't think we definitely need a clinical psychologist or a properly trained medical counselor who handles this. And I don't know whether such exist, to be honest, who know the medical, like you have genetic counselors, whether we have counselors who can talk about reproductive health and the oncology aspects. We'll have counselors in oncology, but do we have here? I don't know. But it's a very, very challenging situation.
I just want to add one thing, not related to the case, but that will be a question also. So it will be very good for me also to know the views of many panelists. Like many times we came across many young individuals who are not married with their erectile dysfunction or any other issues. And then they ask that they want to check the semen analysis. They want to go for semen analysis. So I have made a rule in my practice that I will not refer any unmarried person for a semen analysis. I tell them that if your semen analysis is somewhat abnormal, you will add one more burden to you. So how, whether it is correct or not, you can opine also. But I have made that there is a blanket rule for me. No
I think we'll have
seminarisis for
differing views
unmarried.
about this, sir. I think we'll have differing views about this. So
That's
we'll
why I
start
want.
with Dr. Kapil. We'll start with Dr. Kapil first. Dr. Kapil?
If the patient is wanting a semen analysis, I would definitely offer him, because you think that it will come, it will add burden if there is some problem there. What if there is no problem? He will definitely be relaxed. So he should be aware, and then even if he has problem, let him be aware of it rather than being unaware of it and going into a marriage later on. I think I would say yes, definitely we should offer the semen analysis.
Okay.
Nowadays, many people, I wouldn't say many, but at least few of them are coming with this idea of premarital checkup, especially the ones who are more educated, relatively coming from a higher socioeconomic status, and they want to get themselves evaluated premaritally. Though marriage, it's not just immediately before marriage, say the marriage hasn't fixed, I want to get it checked. So in these kind of situations, so advising a semen analysis would be a comprehensive part of it. So just extending to this part, we are now seeing more and more people. We had in one of the earlier lectures also saying about live-in relationships and the way Western culture has been taking over in India. So, what kind of advice would you give, Dr. Sanjay, for these kind of patients when they come to you for sexual well-being, sexual health, as such? So you're on mute. Sir.
Yeah. Actually, there are many patients. Usually, couple comes in a less situations, but mostly males they come us before marriage. Sometimes they are planning for their second marriage. Usually, these type of patients are more. Their first marriage is broken, and then that's why they want to go for second marriage. Wife alleges. Mostly, I guess patients were alleged for impotence or erectile dysfunction more. But in that cases, we always take the semen analysis because these all parameters. Like I simply do the physical examination, ask for testosterone level, go for semen analysis, and then ask them for a penile Doppler, so that we are sure that there is no obvious organic cause. And then we tell them that there is no organic cause. You can go for marriage. There may be some difficulties in sexual relationship, maybe in second marriages, or maybe in first marriage also. But the difficulties or sexual dysfunctions are treatable and curable. So that advice sometimes is very good. Or sometimes if they are afraid of erectile dysfunction or they are facing erectile dysfunction also, then sometimes these PDE5 inhibitors, they are also helpful.
Dr. Kapil, Dr. Chirag, your views.
Yes, as sir said that the second marriage is quite difficult for these patients who are having, broken marriages before for the sexual regions, and most of them are actually potent, but the problem is performance anxiety. And majority of the cases, what I do is office test. Like I give them a room and they try and fantasize and get a erection done, and I go and check them the hardness, at the hardness score, and length and girth, whatever they want to know, and just reassure them that this is okay and you can go ahead with the marriages. We can get some tests like semen analysis and testosterone on the top, and whatever they need is just counseling and their confidence to come back to perform. That's it.
Okay. Dr. Kapil?
Yeah, I would agree that whenever we see these patients, basically there is lack of confidence in them and performance anxiety, as rightly pointed out. And we also go ahead with and get all the investigations done. I would also include prolactin and a blood sugar, and then total and free testosterone and a penile Doppler. So these are basic investigations I carry out for these patients and reassure them. And then counseling them is very important, giving them a long session of counseling and then following them up at frequent intervals so that they don't loosen up their confidence once again. So that is, again, regular follow-ups and regular sessions with them. That is how they improve.
Okay. So, Dr. Devan.
What I
Yes.
just want to add, sir, majority of the times these penile Dopplers, if there is a dedicated center in well and good, otherwise these penile Dopplers are done by, giving 100 mg sildenafil and they are just doing a penile Doppler to check the test. They are not going, not doing any intracavernosal injections. So these type of tests sometimes can be fallacious for the patient and the doctor, and these reports can be harmful for the patient for his image, and they take it as an arterial insufficiency and they go into more and more complicated system. So penile Dopplers should be used a little judiciously so that
Yes, yes.
the patient should not
Absolutely
be.
correct. I usually refuse this sildenafil test by the radiologists. Some few radiologists ask me, Doctor, why are not doing that? Because they are afraid of priapism. They don't call urologists many times on call. So that is all what practices are going on in India. So that's why they want to do this easier method of giving sildenafil. But I usually resist. Only radiologist who does papaverine and inject papaverine and do that, I send him to him only.
Then it is
Then
okay.
we have actual, yes.
They actually scare away the patient saying that they might have a complication. I had this whenever I used to send regular to one lab and people will get the penile Doppler done. But then when the lab is unavailable because of the, say the radiologist unavailable, referred to a second lab, and I noticed that this second lab, 3 or 4 patients referred and none of them has come back with the penile Doppler report. And the reason was exactly what Dr. Sanjay was saying, that they just scare away the patient because they're scared about priapism, the medical emergency, how to handle it and what to be done. So we are looking up this one end of the spectrum where we are speaking about the young patients. Now, yeah, Dr. Devin, before we go.
Yeah. So I would like to add here something very important also. So regarding the counseling part. So as an embryologist, obviously we don't have direct role, but unfortunately we do have very important role. The reason being, normally, mostly there are majority are female embryologists. So they will give container and they will ask the person to go and give the collection. Because of whatever reason, the person will come back without collection and then he will go away. He never discuss with the female embryologist or andrologist. I think this is one of the bigger issue. Unfortunately, I'm missing my good friend Hetal Shukla. He has very nicely handled such kind of situations when we were working together. He will literally counsel for half an hour the male partner and the female partner, and then maybe he will ask them to come again and basically what I mean to say is counseling from the andrology part is also very important. Andrology means embryologist part. What I mean to say here is
Many times we give a vibrator and it's a female who is handing it over. I'm in a socially awkward situation. We have
yes, exactly.
Young females trying to explain a male who is unable to collect a sample, how to collect a sample using a vibrator.
More drastically.
That's a very, so what we had done is we had one of our OT assistants, a male person. So we told that that person is going to take care if anybody is having difficulty in collecting the sample. So we have to just make some adjustments so that we can see how this fits in. So it's not socially awkward. If you see scientifically may not seem anything wrong, but socially it's a very awkward situation. So we had those persons coming and explaining how to use a vibrator and that, and it becomes very easy. It becomes very easy to handle.
So basically, mean to say is there should be some arrangements. Proper arrangement should be there that the patient should not feel shy for asking any questions.
Yes.
I just want to comment on what Dr. Devin said. It's absolutely right. Many times the patients are referred to us, male patients are referred to us from infertility center because they cannot get the semen sample. So I just wanted to tell you that what happens, you take a scenario of infertility counseling. A doctor is sitting, usually a lady gynecologist, a male, a man, a husband is sitting, and a wife is sitting. So actually, I'm not against women or not against gynecologists, but I have read a very simple sentence somewhere back around 20, 25 years, but that remind me every time. What it was saying that a man is cornered between a gynecologist and a wife during the treatment of erectile infertility, because the demand is more on man. Demand for procurement of semen, demand for sex during ovulation days and all. So these sexuality issues of a man need to be addressed. Like in semen analysis, what Devan said is absolutely correct. It may not be happening in infertility centers, but those pathologists, they will give the bottle and go. That the bathroom is very shabby and everything. We know that we don't have a very good space for that.
Correct.
Even patient wants to do some what you can say, thinking about some his fantasizing and all. He can't do that because that is so obnoxious. Smell and everything is so bad, and all other vices are coming from the vicinity. He may not be able to do the. He may not be able to get erection and then ejaculation. So lot many patients are coming to us. I cannot say, but at least one patient per day I must be seeing who is having such type of difficulties, referred by a gynecologist.
One patient per day is quite high. I don't know how much it is over here. Okay.
We get a lot of patients from gynecologists.
Yeah.
That's why actually one last sentence I will say that to the infertility couples, I counsel them in 2 lines. And 99% they understood, and that is my point. These all 2 lines also I read very long back. I don't know the reference also. They are not my lines, but now nobody claiming it. That's why I'm saying that those are my lines. The lines are: when love making becomes baby making, when love making becomes baby making, pleasure becomes work. And it happens in both the partners, not only in females or males. It happens in females also. They also feel pressurized. They also don't get desirous of sex. They also don't enjoy sex because it has to be done on that day.
Program sex, what we call as.
Yeah. So these 2 lines I always remember, and I always tell to all the patients. And then they say, Doctor sir, yes, हमको ऐसा ही लगता है.
Thank you, sir, for your views. So we'll just take few questions which are over there. One,
sir,
we are discussing.
I will take. Yeah. I have to actually. I'm sorry, but I will leave because I have some function to attend. Okay. So is it okay?
Thank you so much for your content. If you can say, it would be lovely for another 5 to 10 minutes. We'll wrap another 10 minutes.
I will wait for 5.
Yes, sir.
No,
yes.
No. So I will wait.
We are looking at one end of the spectrum where we are, speaking about adolescent males or males in the reproductive health group, like age group. Sorry, in the age group. But what about at the other end of the spectrum? Does it change anything when it comes to reproduction in the elderly male? Any changes which is required from the infertility specialist view, from the view of an uroandrologist view and sexual medicine view as such? So we'll start with Dr. Kapil first, then from the lab end, Dr. Devan and Dr. Rajvi and Siddharth, and then we'll go on to Dr. Sanjay for this question.
Regarding the fertility in elderly male, yes, fertility parameters, I mean, they will be going down with the aging, but that is one aspect. But nowadays with the ART rules coming, majority of them, they are under 55. I mean, all of them are under 55 when you are going in for a ART treatment. And many of them will require an ART treatment because when they are aging, usually their partner is also aging, and then the fertility issues multiply. So in the aging male, the fertility issues are more. Also, the sexual issues start coming in. with their antihypertensives coming and the other medications they are taking, and all these medicines, some of them having sexual side effects. Sometimes they are on psychiatric treatments for various reasons, and all this leads to problems which need to be addressed individually, and customized approach has to be taken for them.
Okay, sir. From the lab and Dr. Raju ma'am, Dr. Devin.
I think there is a very valid point made by Devan some time back. And, and it's not just about the sample collection and other part, even a lot of microbial contamination that happens, in the field of IVF, people are worried about doing conventional IVF because of contamination. And in studies that have been done, and we ourselves did it, the organisms that are found are from the skin or the GI tract, the normal flora of the skin. So in all cases, you definitely need somebody who can talk to the person before collection. And it's very embarrassing for them to talk to a lady in most cases. So I think you need to have somebody to talk to them. And secondly, yes, I mean, when we're talking of infertility, we are just taking it as a reproductive disorder. But to my mind, if you look at the symptoms of infertility, they're emotional. So, I mean, does it really make a difference if they don't have children? The pain is emotional. So, a counseling has to be there at every aspect, whatever the age, maybe the way it is done would be varying. What would be communicated, what pressures they have would vary, but it has to be there along with it for every aspect. So, whether we are talking of sexual health or we are talking of reproductive health or maybe fertility status, it has to be mandatory, and we need to have maybe the embryologists, the lab technicians, etc., play a little role. But at some point, if we find that the issue is major, then you surely need a professional counselor. And I think we need to have more people who are professionally trained in counseling for fertility. I mean, they definitely, the andrologists are doing a great job, the uroandrologists, but when it takes time for these skins, I don't know how much time they can also give in the long run, because the problems are increasing. So we need to look into that front.
Yeah. Dr. Sanjay, your views, and then we'll go on to the last question since we are already running late.
My answer to Rajvi madam is that kindly see a sexologist or sex counselor in your city. So because we always say that what we give to patient is we give time to them. That is most important.
No,
Sex
but
has to be
I agree with you, sir. My only question is, if you look at the ratio of infertility clinics versus sexologists, it's highly skewed. So,
yes.
you need somebody who can do the basics.
Yes.
Plus the social stigma. Actually, we had one of the questions which is down the slides. The social stigma of approaching a sexologist as such.
Yes.
I mean, there's the ground reality. Though we as medical profession being, we may, it may not sound scientific, I don't know, but the social stigma itself that someone has been gone to a sexologist. Same problem, they may be ready to approach a urologist, andrologist, infertility specialist, but same problem ke liye, will they go to a sexologist? I don't know. The common problem is the stigma associated with majority would not. Yeah, Dr. Kapil.
I feel that the whatsoever facility of the counselor or an andrologist you have should be on site. It should should not be referred outside, because patient coming to an IVF clinic is much more happier being there than being asked to go to some other place, visit some other doctor, because that, as you rightly said, so many social issues start coming with that. So patient is very happy, and counselor should be there itself. So counseling has to be at the clinic, and even the andrologist, we are doing counseling for so many patients, but I myself am going to attach to nearly 19 or 20 IVF centers in Indore. So I cannot go and counsel every day to in each of the center. So definitely we have to have few patients who can be taken counseling by the local the counselor there, and those who are not still handled by them should be referred to us.
Yeah, right.
And sir, one thing I wanted to add is, we are talking about counseling. So from my side, I feel there are two type of counseling which is done in an IVF center. One is scientific and technical, which can be done by embryologists and clinicians, and second is psychological counseling. So before going to the technical and scientific counseling, the patient should be advised for the psychological counseling, because after that it would be very easy for patient to understand the further scientific and the technical way, which was the same case in the 16-year-old case which we are talking about. If that person was be suggested for the psychological counseling first, and then it was be sent to the lab or a clinician, then it would be way easier for him also to get on with the process. That is what I feel.
Yeah, yeah, rightly said, Siddharth, because it's a common thing which we do notice across any specialty in medicine as such, where the patients are more attached emotionally to a counselor. They would many a times they would not agree to a treatment which the specialists know is the best interest of them, but they would listen to a counselor. Probably it's because they connect to them on the emotional front, and they see the patients probably feel that they are being seen as a person rather than for treatments. The difficulty is the amount of time which it comes back to that which is being given to a patient as such. How much ever we give, but it's more about the technical side when they come to say in infertility field to a doctor and an embryologist, infertility specialist or an embryologist. It's more about what's the sperm count, has it improved, egg count, has it released properly, did OITI went on well or not, has the embryos formed well or not, because there's not enough of time to discuss these things in detail as well. So the human part of the patient takes a backseat probably over there. And that's the reason counselors have a huge role in a medicine, especially in a field like infertility, where a couple is involved directly. So I would like just the last slide, since we are already running late, just the last slide, sir. If you can share the eighth question over there. If there's one thing you would want like to change about public awareness, medical education, or healthcare delivery, and what you would like to see which would improve it. So we'll take from all the panelists, and if we have Dr. Sanjay here, we'll take his views first. So sir has been kind enough to stay back. So we'll start with him.
Thank you very much. I always say that in front of doctors, whenever I go and have my presentation or something like that, that we all should understand not only infertility specialist or sexologist or gynecologist, but doctor as a whole, because sex issues are common in many illnesses. Right from pregnancy to infertility, there are sexual problems. A couple faces, or a man faces, or a wife faces. So let us talk. Sex is the most important thing which we should keep always in mind, and that needs time. Patient needs time. We'll have to give them time, at least 5 to 10 minutes. It doesn't need much more. But what I said, that exact sex, whether it is happening or not, for infertility is very important issue. So
Right.
I think I'm in hurry also, and
Thank you so much for joining, sir.
thank you very much for inviting me and allowing me to share my experiences. Thank you, Dr. Ved. Thank you, Akash. Thank you, Chirag, and thank you, Bindu also, because Bindu and me are from Nagpur. So
Yes.
yeah,
Same function.
Thank you,
Yes.
thank you,
Yes, sir.
sir.
Thank you
Thank you
so
so
much,
much.
sir.
Thank you.
thank you very much.
Yeah.
So
Next, we'll,
am I permitted to leave, sir?
sir,
Yeah, please,
please,
please, sir.
definitely,
Please.
sir. Thank you
Thank you
so
so much.
much.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you.
Thank you. Next, we'll have the opinions of the embryologist. Then we'll go to the uroandrologist as a end. So Dr. Devin, Dr. Rajvi, and Siddharth next. Yeah.
Okay, so what could we change? I think.
Yeah, one thing which you would like to change in terms of this is, what you feel requires change, requires
Yes,
a change over
so
there.
I think that is what we are here, basically Andronet, public awareness. So I think that was one of the reason we started this Andronet, for scientific education also and public awareness also. So I think, and in my this first lecture, I was asking the question regarding the education. So maybe the education should start as early as possible for early analysis of semen or whatever, fertility. So I think education is also very important.
Right. So, including sex education as a part of curriculum in a way which can be delivered probably at the school level, at the high school level. That's the right time, where instead of people relying on curiosity and on the internet for everything, a standardized curriculum to be a part of it. Okay, sir. Dr. Rajvi?
Yeah, I think if you ask me one thing, we have definitely, the environment is playing a big role in the increase in infertility. So I think at the young age itself, right through, we have to increase public awareness. I mean, on one hand, the number of patients are increasing, infertility is increasing, male infertility is, I mean, I've seen it over the decades. So one thing is extensive public awareness about environmental impact, whether it's plastics or pesticides or phthalates or whatever we are talking about. I think we really need to go on and on and on about it, and maybe somewhere something gets into somebody's mind. And, it's the children who will bring about the change. So even if you don't directly tell them about reproductive health, but, the teenagers, they will possibly bring about change and reduction in the impact of all these things. So that's where I would really want to go into the environmental factors and fertility.
Tomorrow's future. That's right.
Yes.
Because they are the ones who are going to be there.
Yeah.
I would just add one thing to you. I've seen that now, since the world is moving more towards cosmetic and the procedures, what you exactly mentioned about the environment in terms of what products they use,
Yes.
even simple things like fragrances, added fragrances. I was reading a paper where they said that majority of what people label as fragrances added in the products that have endocrine disrupting agents.
Yes.
They want to just conceal it. They don't want to reveal the name. So they just add fragrances towards it. So be wary of it, what people are using, and that could be a major factor in terms of environment.
Also, last point, the environmental factors which are associated with fertility or infertility are also leading to a rise in cancers. So I think that way we can alert people much more also, because that creates a big fear. So we are creating fear, but I don't think there's any harm in that. It's for the good of society in the future.
It's rather than fear, I would say the awe and surprise, shock and surprise, rather that to grab the attention.
So we get, people to reduce small things, but which will make a change. Like you said, the future, the younger generation may bring about the change.
Siddharth, the younger generation, he has to add over here.
Yes, so there are two points from my side right now. If I talk about myself and we all get news quicker on social media rather than watching the news channels or other things. So right now we are in particular in India, we are lacking the awareness which should be given on the social media rather than on the platforms like this, because these platforms are be followed by only scientific people or the people who are from this particular branch, but the social media is a thing which is used by everyone. So if I tell you a commerce student would be never be watching this kind of podcast and this kind of conferences in their lifetime, so for them it is just the social media. So what I feel in India, it is at the lowest point about the sharing the awareness related to the reproductive sciences. So it should be increased. And second is building a eco-friendly environment, which exactly Rajvi ma'am told. Right now, we are moving to the electric cars. We are reducing the use of the petrol to improve the environment. This all small things, also the health, the food habits. Right now, people are more aware about their food habits rather as compared to before. Right now, people have started looking about the calories, the amount of the content of the food products which are written on the packets, which was not before. So we are going in the right direction, but we just need to push it in this particular way also, rather than just focusing on the scientific ways.
Yeah, rightly so. It's about the reach, Siddharth, if I can put it in one word, the reach what you are
Yes,
speaking about.
yes,
And right now, Facebook, Twitter, and they are old, and Insta is the new one, Instagram being the platform. So on that, maybe as a part of Andronet, it can be done in terms of increasing the reach. And once the reach increases, the message which you want to put gets to more people, and the purpose gets solved as such, the basic
yes,
purpose. And like he said about calories and everything being watched, people being more as such aware of these things. The reason was because of the problem which was being created at first hand, people running towards anything which is labeled as organic, especially
yes.
for anything which is food and that. But whether it's actually organic or not, that's a different part
We
of
don't
the
know.
story. But at least people
Yes.
are getting aware and using those. Thank you, Siddharth. And Dr. Kapil.
Yeah. Well, everything has been covered by Dr. Rijvi, Dr. Siddharth, and everybody else. So I think we have covered everything. One thing which I really hope and pray is that someday we come to the conclusion, we are on one page, as far as the semen analysis goes, as far as the morphology goes, because so many different reports, even in IVF centers, reports from one center vary as compared to the other center, and it becomes really difficult. So I really want one thing which should change is that we should be on one page. We should agree to what is what. And then we should, so that things become easier for common people, because nowadays common people are getting confused. One center says 0% morphology, the other says 4%, somebody else says 2%, and the patient doesn't know whether he is going to have his own baby or he's being rolled over, and then they start having mistrust. So this is one aspect I feel one needs to be very, one should work on that.
Yeah, standardization and reproducibility of it, and uniformly accepted standards, so that there's no confusion over it. Thank you so much. It was a wonderful panel. And before closing, we'd obviously have remarks from my co-moderator, Dr. Chirag, as well. And before that, I would like to add that we are dealt with reproductive health as such, where we have looked a case scenario from young adolescent persons to the elderly one, and it's quite varied. The requirement at different ages may be different. We need to understand the psychology, the psychological aspect of it first, deal with the psychological aspect as was being highlighted earlier, deal with the emotional aspect, then go towards the scientific aspect in terms of what is required. With changing times, you need to change in terms of what the treatment may be required, what would be the cost for it, and how you can approach the case as such. Thank you, everyone. Dr. Chirag.
Thank you, all the esteemed panelists. I learned a lot. Thank you.
Thank you, everybody.
Thank you, everyone.
Thank you.
Over to coordinators. Thank you, everyone.
I think it was excellent panel, and I know that time is very short. We were thinking about that we will take at least 1 hour, but it was not possible. But whatever is done, it was excellent, and the knowledge sharing over this panel discussion, I think I also learned so many things. Of course, I want to say about that. Siddharth was telling that about sharing the that using that social media platform. That both the things required actually. If you are not updated your knowledge regarding the scientific platform, so you will not be able to make awareness in public also. So these things both together we have to have, because without that it is not possible. And of course, we people till of my age, actually I can say, we are not aware of this kind of Insta and everything. So you people are also there, so you can take it forward. It is now your responsibility, because we can help you, we can support you in scientific way or whatever you want, but you have to do these things. Because Dr. Rajvi and I discussed so many times regarding this male infertility things. In so many meetings we discuss about this, but it was not, we could not do these things. That is the big issue with us. But we have to have do our work also. So that's why I started Andronet, and you people can take it forward for that Insta and everything, for
Sure.
public awareness. Right?
Yes,
So,
sir.
but so many things we learned, and I think it was excellent program, excellent webinar. Thank you so much.
We have moved a long way from a time where it was so difficult to convince the man to give a sample. I mean, I've seen days when a man walks in and says, "Baby chahiye." Semen analysis, dono बीवियों को लेके आया हूँ. So from that we have moved a long way. So I think we are moving, but a lot
हमसे हो
needs to be
सकता
done.
था हमने किया. Actually,
There's a lot that needs to be done.
Yes.
It's a good forum. Thank you.
Thank you so much. Thank you.
Thank you. Bye-bye.
Thank you.
And thanks to the technical team, and thanks to that UNS for providing us this platform, and thanks to all the conveners and all the coordinators and all moderators, speakers, everyone. Thank you so much. Thank you.
Thanks to you, sir.
Thank you. Thank you.
Thank you.
Bye-bye.
Thank you,
Thank you.
everyone.
Bye. I think अच्छा सा हुआ program.